Chair Ratty, the broadcast is ready, and you may call the meeting to order once you're ready.
Thank you. So good afternoon, everyone, and welcome to the March 18th meeting of the Senate Committee on Health and Human Services. We're glad to have you here. We have a full agenda today. Just by way of flow, we'll be hearing SB 168, SB 175, and SB 251. Then we will be doing a work session on SB 49 and SB 156. We may take a break in between bills to do the work session, just so we can allow some people to go home. But in the meantime, that's the run of show, if you will. Just a reminder to everybody that we are doing these meetings virtually, and therefore the public is not able to enter the building. Many of you have participated already, but just in case this is your first hearing, if you want to know how you can participate, please go to the Nevada Legislature website. You can just Google it, it pops right up. And there's a help tab on the top of every page that will help you register for the meeting so that you can do public testimony if you'd like, or you can send in written testimony and we can get it onto the record, or you can participate in an opinion poll. So with that, I would like to invite, how about we take the roll? I think what I'll do is I'm just going to note for the record that myself, Senators Hardy, Kieckeffer, and Harris are here, and please mark Senator Spearman excused and mark her present when she joins. All right, with that, I'd like to invite Senator Roberta Lang to present SB 168.
Thank you so much. Good afternoon, Chair Ratty, Vice Chair Spearman, and members of the HHS Committee. My name is Roberta Lang, and I am the Senator representing District 7 in Las Vegas and Henderson. Today, I would like to introduce Senate Bill 168, which deals with two items: cannabis curbside pickup and cannabis packaging and labeling. In your packet, you will see an amendment. We are replacing SB 168 with the amendment language. I am joined today by Lake Martin, Executive Director of the Nevada Dispensary Association. We are presenting this bill and amendment together in collaboration with the Cannabis Compliance Board. Following the presentation, we are available for questions, as well as the CCB Executive Director, Tyler Klimas, and technical questions can be addressed to Matt Walker. I'd like to introduce Lake Martin, and she will walk you through the bill presentation.
Thank you, Senator Lang.
Thank you.
Good afternoon, Chair Reddy and members of the committee. My name is Lake Martin. I'm the Executive Director of the Nevada Dispensary Association. The Nevada Dispensary Association represents the majority of dispensary owners in Nevada. Briefly, I will summarize what the bill and amendment intend to do, and then we'll go section by section. We'll cover curbside pickup first, and then move to packaging and labeling. So this bill would allow dispensaries to continue to provide curbside pickup to customers. Curbside pickup was authorized by Governor Sisolak's Declaration of Emergency Directive 16, issued on April 29, 2020. The Cannabis Compliance Board provided written guidance for how dispensaries should implement curbside pickup on May 1, 2020. Initially, curbside pickup helped dispensaries comply with COVID-19 restrictions, reducing in-store capacity. As it turns out, customers really liked the convenience of curbside pickup. It's especially convenient for elderly customers or medical patients who have difficulty or prefer not to leave their car. Dispensaries asked the NGA to work on making curbside pickup a permanent feature. The CCB agreed that curbside pickup has worked out well, and the CCB and the NGA have worked together on this legislation. The proposed bill language would allow for curbside pickup and authorize the CCB to adopt regulations to implement it. Those regulations will be just like what's being currently implemented under the current guidance. Some of the features of curbside pickup include designated spaces, security cameras with a direct line of sight, no one under 21 years of age may be in the vehicle, and orders must be placed in advance. The proposed language of the bill will also allow local governments to determine whether curbside is appropriate based on the location's characteristics or compliance with other local regulations. Moving to labeling, the bill removes language in the statute, the amendment in particular, removes language in the statute that would limit the ability of the CCB to make common sense reforms to the Nevada cannabis compliance regulations dealing with packaging and labeling. At the same time, none of the proposed language would alter warnings or other information that's required to be conveyed in statute. The reason for the proposed revisions is to allow the CCB and stakeholders to develop packaging and labeling regulations that have clear, easy to understand definitions that clearly convey safety information and that are in line with best practices and safety standards. Many of the packaging and labeling regulations have not been updated in years and therefore do not reflect modern production, new safety standards, or public health expertise. The current patchwork of statutory and regulatory language is confusing and duplicative, which can obscure critical safety information that ends up being buried in overly detailed text and warnings. Now, I want to direct you to the proposed amendment as we go section by section. Section 1 of the amendment adds specific language to NRS 678A450, authorizing the board to adopt regulations relating to packaging and labeling of cannabis products. The board has already adopted regulations to this effect under the authority given to the board in other sections of this statute, but this language seeks to make it all the more clear. Section 2 amends NRS 678B to add the language in Section 3 authorizing curbside pickup. Section 3 explicitly allows for curbside pickup at cannabis sales facilities and states that the CCB shall adopt regulations necessary for implementation. Subsection 2 also provides that local governments retain authority to determine whether curbside pickup is appropriate at a particular location. Section 4 moves required labeling language from 4B to 2H and removes the language affix a label. These warnings, ingredient, and THC information do not go away. They move to the section on warnings in NRS 678B 520. Also, both the keep out of reach of children and amounts of THC are already required by cannabis establishments in other parts of this section. So this section still requires that the information be conveyed, but it doesn't require the production facility to convey it by affixing a label. Similarly, where under subsection 7, there's a list of warnings that must be conveyed by written notification, this bill seeks to revise that language to state instead that the information shall be conveyed in a manner to be determined by the board. That's to allow the board to adopt regulations that factor in the expertise and guidance from other jurisdictions regarding how warnings are best conveyed. Section 5 does not remove any language from the statute. It merely deletes language from the bill as we've agreed with the CCB. So this concludes our presentation of the bill and the amendment, and we're available for questions, as is the CCB, who, as I mentioned, we've worked closely with in drafting this bill and amendment.
Thank you, Ms. Martin. So committee members, obviously I don't have all of my tools available to me. So it looks like, I'm gonna say Senator Hardy has a question.
Thank you, Madam Chair. Is there any limit on the advertising or signage that comes with this curbside pickup?
Senator Hardy, Lake Martin, Nevada Dispensary Association, for the record. I would actually seek to have the CCB comment on their guidance, if they're available, related to what's currently required by the under curbside pickup under the guidance.
Mr. Klimas, would you like to reply?
Sure, thank you, Chair. Tyler Klimas for the record, and thank you, Senator, for the question. We'll continue this line, and I will ask Kara Cronkite, who heads audit inspections in my agency, to talk about some of the restrictions for curbside that currently exist.
Thank you, Mr. Klimas. That's the first phone a friend that we've seen.
Thank you, Director Klimas, and good afternoon, Chair Addy. Yeah, we do currently have a lot of restrictions in place through policy that we would incorporate into regulation regarding curbside pickup. We require that all IDs of every person in the vehicle be checked, that they pre-order, and we also encourage them to, sorry, I'm on my head. They require PPE as well, so they have to wear masks and gloves when handling any product or orders. And if there was any specific questions that you guys have, I'm happy to answer those as well. Sorry if I didn't answer your question properly.
Any follow-up questions?
Madam Chair, I'm not sure I had the answer to, is there a limit on advertising or signage that is involved with the curbside pickup? Or are we using this as a bigger sign, a more advertising, or are we keeping within the bounds that already exist for advertising and signage at the dispensaries?
Sure, Senator. Sorry, Kara, I'll let you go.
Kara Cronkite for the record. Yes, we are keeping with the current requirements for advertising and signage that currently exist.
Thank you. Thank you, Madam Chair.
You bet. Any additional questions from the committee?
I'm sure.
Senator Kieckhofer.
Thank you. I appreciate the amendment. Most of it seems to make a lot of sense to me. The insertion of the amended language regarding the labeling of products that are for sale and removing the language as it relates to production and the labeling of that production. So is this just to recognize how product flows through the sort of production, manufacturing, and distribution chain, so that labeling is really focused on the consumer rather than sort of every step in the process?
Thank you, Senator Kieckhofer. Lake Martin, Nevada Dispensary Association, for the record, that's exactly right. It's to allow flexibility for the CCB to determine how the warning should be best conveyed versus having specific stops for everybody has to apply their own label.
Appreciate that. And then to follow up on that, on the amendment, page 8, the top of page 8, when it says we're striking written notification of the following information, and then just say that the cannabis sales facility shall convey the following information to consumers. Is there anything that says that can't be just verbal, that you can't just, or that you can't just have a sign posted on the wall behind the register or something like that, that there has to be an actual delivery of content?
Thank you, Senator. Lake Martin, Nevada Dispensary Association, for the record. The intention is to make sure that the information is conveyed in the best way possible to the consumer. So there isn't an intent that it would be on a sign or verbally conveyed. What we're sort of looking at, is it a printout at the point of sale versus a sheet that is slipped into the exit bag versus a label on the product itself. And so leaving it to the CCB to handle that in regulation to determine what's the best manner to convey that. But I don't think that the CCB has any intention of allowing those warnings to be given verbally.
And Madam Chair, if I may, through you to Senator Kieckhofer, Matt Walker, for the record, I would point you to the presentation briefly on both of those excellent questions, in the manner in which something is prescribed to be on the label versus on the sticker attached to it. You can see that on the smaller products, what results is less information being meaningfully conveyed to the consumer. And so we're just hoping to clear the statutory path so the CCB can comprehensively take up these regulations and ensure that not only is the information made available, but it's made available in the best way to actually absorb the information for the consumer and compare among products.
Excellent. Thank you very much. That was all, Madam Chair.
So to follow up with that, I'll just take the liberty of jumping in here. So particularly to Mr. Klimas. So the intent is still that it would not be up to the dispensary themselves to decide how they want to convey the information, but rather that we're taking it out of statute and putting it into the regulatory framework. So your body would still be doing that regulatory process, would be giving them detailed instructions, and it would be a little bit more flexible to change because it's in the regulatory framework instead of the statutory framework. Is that the idea here?
Chair, thank you. Tyler Klimas for the record. That's absolutely the idea here.
Okay. And would you just say for the record that you do not intend to loosen the labeling or the standards in terms of the information that consumers need to stay safe?
Yeah, absolutely. One of the CCB's core principles, public health and safety, and so that will be top of mind whenever we promulgate any regulations around what is conveyed as far as information to the consumers.
Thank you.
Additional questions from the committee? All right, seeing none, we're going to go ahead and open it up to public testimony on SB 168. We're going to start. I'll ask you, Senator Lang, is there anybody in the Zoom who you were expecting to testify under in support of the bill, or can we just go straight to the phone lines?
Straight to the phone lines, please.
Thank you. So I'd like to open up testimony, BPS, I'd like to open up testimony in support of SB 168.
Thank you, Chair. Callers, if you'd like to testify in support of Senate Bill 168, please press *9 now to enter the queue. Once again, that is *9 now to enter the queue for testimony in support of Senate Bill 168. Once again, please press *9 now to enter the queue for testimony in support of Senate Bill 168. Chair, at this time, it appears no callers are wishing to testify in support of the bill.
Thank you. Let's go ahead and open up testimony in opposition. I should have said testimony will be limited to 2 minutes.
Thank you, Chair. Callers, if you'd like to testify in opposition to the bill, Senate Bill 168, please press *9 now to enter the queue. Once again, we are on opposition to the bill. Please press *9 now. Callers, it appears that one of you have left your place in the queue. So if that was an accident and you do want to testify in opposition to the bill, please press *9 now. All right, Chair, at this time it appears no callers are wishing to testify in opposition to Senate Bill 168 either.
Great, let's go ahead and open up the testimony for SB 168 in neutral, also limited to 2 minutes.
Absolutely. Callers, if you'd like to testify in a neutral position for Senate Bill 168, please press *9 now to enter the queue. Once again, *9 now to enter the queue for a neutral position. All right, well, the caller with the last 3 digits of 972, please slowly state and spell your name for the record. You'll have 2 minutes and may begin now.
Thank you, Madam Chair and committee. My name is Darrell Lacey, representing Finance 13. Actually, I wanted to testify in support of the bill. And
I will go ahead and let you do that. Please go ahead.
Okay, thank you. Finance 13 supports the SB 168. Had a friendly amendment to maybe change some wording, but other than that, we strongly support the bill and think that it was something that needs to be incorporated into the statutes because it's very successful during the emergency rules, I guess. Thank you.
Thank you. All right, we are in neutral testimony, so let's go ahead and see if there's anybody else who'd like to testify in neutral.
Certainly, Chair. Callers, if you'd like to testify in a neutral position for the bill, please press *9 now to enter the queue. Once again, we are in neutral. Please press *9 now. Chair, at this time, it appears no more callers are wishing to testify for the bill.
Okay, thank you. We'll go ahead and turn it over to the sponsor, Senator Lang. Do you have any closing remarks?
Thank you, Chair Ratty. I think that in closing, this is not something that's new. It was something that was already happening in COVID, curbside pickup. It was hugely successful for the business owners and for the patrons that came to pick up product at the stores. And so what this bill is doing is just putting this into law that we can continue doing what we were already doing that was really successful. Additionally, the labeling is something that keeps in mind how we want to make sure that these products, when they go into people's homes, they're safe and people know what's in them, and they things that look like candy are marked so they don't look like candy and keep out of the reach of children. Those kinds of things are really important, and I applaud my partners in this bill for bringing this forward. I think these are all important components of the industry, and as we move forward, I hope that we can get your support on this important bill. Thank you so much.
Thank you, Senator Lang. Members of the committee, last chance for any questions for the sponsors of the bill. All right, seeing none, I'm going to go ahead and close the hearing on SB 168. And I'm going to compliment Vice Chair Spearman on her timing because that was perfection. So we are going to go ahead and move into a work session, and then we'll resume bill hearings. So Ms. Kamlasi, if you could take us through the work session.
Thank you, Madam Chair. Megan Kamlasi with the Research Division of the LCB for the record. We have two bills on the work session today. The first is Senate Bill 49, and the second bill is Senate Bill 156. Senate Bill 49 was heard in this committee on February 4th. The bill makes various changes related to cannabis. It removes authorization for the Cannabis Compliance Board to take the testimony of a witness by deposition in hearings before the board. It authorizes the board to adopt policies and procedures to waive registration requirements for people who have an ownership interest of less than 5% in a cannabis establishment. And it revises labeling requirements for all cannabis products offered for sale to include the words "this product contains cannabis" rather than "this is a medical cannabis product" or "this is a cannabis product." The bill sponsor proposed 3 amendments during the bill hearing. It is attached to the work session document, and essentially the amendments authorize the chair of the CCB to approve at the request of the respondent or a petitioner or on agreement by both parties, 1 or more extensions to the 45-day requirement within which a disciplinary hearing must be held. It authorizes the executive director to serve a complaint, and it authorizes the board to employ the services of people who it considers necessary to assist with the hearing, with hearing disciplinary proceedings.
Thank you. So, members of the committee, we did have some testimony in this bill hearing that came from individuals who were concerned about the ability to do background checks in publicly traded companies. And the stakeholders who were interested in that issue did meet with the Cannabis Compliance Board representatives multiple times in order to see if they could work something out. I don't think we came to a level of 100% agreement, but what we did get to is that conversation with Mr. Klimas about that he believes that many of their concerns could be addressed through a regulatory process. So I'm going to ask Mr. Klimas to talk a little bit on the record about those conversations and where we ended up.
Thank you, Chair. Tyler Klimas for the record, and that account is correct. We do have a number of publicly traded companies in the industry. NCCR 5, that's our regulation that deals with publicly traded companies. It deals with background checks, and it also deals with waivers. These waivers of ownership under 5% allows for publicly traded companies that have a number of shareholders to continue to do day trading and shareholders to purchase shares and sell shares without having to go through the complete registration process that any owner over 5% has to do. Certainly, there has been input from publicly traded companies about thresholds, 5%, 10%. There are some suggestions on how to streamline that process. As the CCB, we totally understand those concerns, and we've always had an open door policy on that. At the last board meeting, it's on record that we will be holding a workshop. We do both informal workshops and formal workshops whenever we make regulatory changes, so there'll be plenty of opportunity to talk through NCCR 5. We certainly encourage all input from all of our publicly traded companies and all our stakeholders and the public as well. And so we certainly look forward to continuing to refine NCCR 5. We look forward to continuing to refine all of our regulations as they are very much living documents. And so we did have conversations, Chair. We did talk about those opportunities for input, and I certainly believe that a lot of those suggestions and concerns can be addressed in a public setting at a workshop in front of the board.
And so thank you, Mr. Klimas. Just to put a finer point on it, would you say that acknowledge that there could be some better processes when it comes to publicly traded companies, and that's the intent of opening up those workshops on this part of your regs?
Chair, this is Tyler Klimas for the record. That's correct. With publicly traded companies and different ownership structures, there's so many different scenarios and situations that go along with ownership and transfer of ownership and stock shares and selling stocks. And so, yes, we certainly anticipate getting into NCCR 5 and making changes that account for all those different situations that come up and certainly help to streamline the process for both the regulators and the members of the industry.
Okay. So members, we wanted to get that on the record. Of course, we're in work session, not necessarily a relitigation of the entire bill. So we'll allow for some clarifying questions to make sure you understand what you're voting on based on the results of those conversations. So Senator Hardy.
Thank you, Madam Chair. I'm looking at the amendment, the third amendment, where it says provides for the board to employ additional services to assist the disciplinary proceedings of the CCB. Number one, is it subject to the open meeting law? Do we know the qualifications of those people who are employed to help, or preclusions of who's not supposed to be able to help, meaning some, for lack of a better word, nefarious person who has been convicted of illegal marijuana or some other preclusion for something that we don't want a virtual marijuana mob, as it were, being the people who are going to, quote, help, unquote, get this over a finish line.
Mr. Klimas?
Yes, thank you, Senator, for the question. Tyler Klimas for the record. It's actually, at the end of the day, this allows us to hire an administrative law judge, Senator. So very similar to other state agencies. The CCB does not have its own administrative law judge. In fact, we've been borrowing taxation's administrative law judge, which, thanks to taxation, that's allowed us to process our disciplinary hearings. But that's what this allows us to do, and that is the only services that we would employ through subsection 10 here, Senator.
This will not include an increase fee or on the people who are paying for it.
Thank you, Senator. And the administrative law judge is in our approved budget from the governor's approved budget. So those funds are currently in there as it's approved now.
Thank you, Madam Chair.
You're welcome. Senator Harris, did you still have a question?
I will make my comment on the motion once it's made.
Got it. Thank you. Any other clarifying questions? All right, seeing none, I'm looking for a motion of amend do pass.
Amend do pass.
Got amend do pass from Senator Hardy. I see a second from Senator Spearman. Opening it up for discussion. Senator Harris.
Thank you, Chair Ratty. You may or may not recall during the hearing, I expressed a little bit of concern about the 45-day extension and its ability to kind of be done in perpetuity. I noticed here it still says may approve one or more extensions, and so I would just encourage you maybe through the regulatory process to put some constraints around that so that there isn't this ability to continually push that 45 days out whether that be clear instructions on when a 45-day extension will be granted, or even just some limits on how many times that can be done. So at this time, I'll vote it out of committee, but will reserve my right to change my vote on the floor.
Appreciate that, Senator. Any other comments? All right. Seeing none, Secretary, if you could call the roll vote.
Senator Hardy,
Yes.
Senator Harris,
Yes.
Senator Kekeffer,
Yes.
Senator Spearman,
Yes.
Chair Ratty.
Yes. All right. Motion passes. Let's see. Senator Kekeffer, would you be willing to do the floor statement on this one?
You got it.
Thank you. Okay. We're going to move on to SB 156 work session. Ms. Kamlasi?
Thank you, Madam Chair. Megan Kamlasi for the record. Senate Bill 156 was heard in this committee on March 2nd. It expands the authority of the Division of Public and Behavioral Health to issue an endorsement as a crisis stabilization center, not just to a psychiatric hospital, but to any licensed hospital that meets certain requirements. The bill expands the existing requirement that DHHS take any action necessary to ensure crisis stabilization services provided at a psychiatric hospital with the crisis stabilization center endorsement are reimbursable under Medicaid to include such services provided at any hospital with this endorsement. And it also makes conforming changing to existing law requiring health maintenance organizations or managed care organizations that provide services through Medicaid or the Children's Health Insurance Program to negotiate in good faith to include a hospital with an endorsement as a crisis stabilization center in their provider network. 2 amendments were proposed, and one was mentioned during the bill hearing and the other one came after. Joan Hall of Nevada Rural Hospital Partners proposed authorizing a rural hospital to obtain an endorsement as a crisis stabilization center, even if it's not accredited by certain hospital accrediting entities. And that would allow rural hospitals to get an endorsement as a crisis stabilization center. And the second amendment was proposed by Mary Walker, representing Carson Tahoe Health. And this amendment expands the accrediting agencies listed in Section 1, subsection 5B, to include the Center for Improvement in Healthcare Quality, DNVGL Healthcare Facilities Accreditation Program, which is merged with Accreditation Commission for Healthcare, and any of these or their successor organizations. So this is a similar expansion of accrediting to apply to all hospitals, whereas the accrediting entity that was previously listed in law specifically applied to psychiatric hospitals. And I believe we have representatives of both amendments, as well as DPBH on the video conference if there are questions.
Thank you, Ms. Kamlasi. So on this one, the intent of the bill was to expand this from psychiatric hospitals to all hospitals, and we needed to do some work on the details of the wording to make sure that we were really getting to all hospitals. As Ms. Kamlasi mentioned, we do have representatives from the amendment if you have any clarifying questions.
I would amend to pass.
Is that Senator Kekeffer, is that a second or a question?
That was a question. I apologize.
Okay, would you like to second and get to the question and dialogue and
Sure.
discussion? All right, so I've got a motion by Senator Hardy, a second by Senator Kekeffer, and we'll open it up for discussion. Senator Kekeffer.
Thank you. If we adopt amendment number 2 as submitted by Mary Walker, do we still need to adopt amendment number 1 as submitted by Ms. Hall, since I think the intent of 2 is to capture 1?
So our understanding is from the Department of Health and Human Services that we do need both to capture all of the different types of hospitals.
So rural hospitals are not, I'll just take your word for it. I'm good.
I think we have somebody here from DHHS if you'd like them to explain. No? Okay. Appreciate the concession to move the meeting forward. So we have a motion and a second. Any other discussion? Seeing none, Secretary, please call the roll or call the roll vote.
Senator Hardy,
Yes.
Senator Harris,
Yes.
Senator Kekeffer,
Yes.
Senator Spearman,
Yes.
Chair Ratty.
Yes. And I'll go ahead and take the floor statement on this one. Okay, that's going to close out our work session. If you are on the Zoom meeting in order to support either the work session on either SB 49 or SB 156, you are free to drop off. There won't be any other action on those two bills today. The same would be true for SB 168. That hearing is closed and there won't be any other action on that today. So with that, we're going to go ahead and open up the hearing on SB 175, and I'm going to invite Senator Neal to the virtual dais to present the bill.
Okay. Hey, good afternoon, Committee on Health and Human Services and Chair Ratty and Vice Chair Spearman. So I am here to present SB 175, which is a bill about lupus. And before I get started, I wanted to show a quick video about what is lupus before I get into why I brought this bill and introduce my co-presenters. If that's all right, Chair, can I share?
Apologize, Senator, that's fine.
Okay, thanks.
Systemic lupus is a chronic inflammatory disease. It's an autoimmune disease. So basically, the immune system starts recognizing parts of somebody's own body as foreign and starts attacking them. It doesn't have any cure, so it generally is lifelong. So it mostly affects women of reproductive age. It's most common in African Americans, followed by Hispanics, Asians, and Caucasians in the United States. It can occur later in life, but the classic dogma is that it's females of reproductive age. It's 10 times more common in women. It can have varied presentations. Since SLE can attack any part of the body, everybody can present in a different pattern. What they go through depends on what kind of lupus they have. Some patients will have a much more severe disease where they develop kidney, lung, or brain involvement. Some patients will have mild disease, mostly with rashes and joints. Occasionally, you can tell what kind of lupus they will have based on their serological profiles, and some autoantibodies may signify a higher risk of some subtypes of lupus. But in general, it is a chronic disease that can flare from time to time. So patients can do very well between these flares. In general, they may have an average of 1 or 2 flares a year. And during those flares, again, depends what the disease is attacking, but they can be disabled. They may miss days of work. It may affect their family life. It can affect their functional ability to do activities of daily living. So whenever those flares occur, we need to approach them judiciously and treat them.
Okay, thank you for that, Chair. Lupus is one of these invisible diseases that I felt like I needed to show that video so we could get on the same page about what it is. It's not cancer. It is an autoimmune disease that affects the body very differently. The Lupus Foundation of America estimates that roughly 1.5 million Americans and at least 5 million people worldwide have a form of lupus. As stated in the video, it mostly strikes women of childbearing age. However, men, children, and teenagers develop lupus. 90% of the people living with lupus happen to be women, and most of them are between the ages of 15 and 44. People with lupus can experience significant symptoms such as extreme fatigue, hair loss, cognitive issues, physical impairment that will affect every part of their life. Many will suffer from cardiovascular disease, strokes, disfiguring rashes, and painful joints. The best estimates that research puts out there is that there is an incidence of 16,000 new cases a year for lupus. There are 4 types of lupus. There is systemic lupus, which is a majority of the cases, 70%. It affects the heart, lung, kidney, brain. Then there's a lupus that affects the skin. There's drug-induced lupus that can occur if you have a certain kind of medication. And then there's neonatal lupus, which is a very rare condition that affects the fetus. I wanted to bring this bill because not all the states have passed legislation, and it's been sporadic at best. Congress has, but starting in 2004, the CDC founded a network of the National Lupus Registry in selected counties, California, Georgia, Michigan, and New York, and at selected Indian Health Service regions. Each site focused on 1 to 2 specific races or ethnic groups. Michigan and Georgia sites were the first of these registries, and they served as a prototype for the development of the later registries in this network. These CDC lupus registries are unique and groundbreaking. For the specific purpose of their current research, they follow the treatment history, healthcare access, and natural history of the severity, the morbidity, and the mortality rate of lupus patients. My bill, SB 175, is going to start tracking these variants, get the data on what is happening in the space outside of the hospitalizations that are occurring for the lupus patients. The most recent event that's happened around lupus funding has been that Congress actually in 2020 passed $8.5 million that went to fund the lupus registry, indicating that there was a clear interest to recognize the importance of what is going on within the space. Black women with lupus were diagnosed at a younger age, and they have a higher risk of developing lupus kidney disease and end-of-stage kidney disease as compared to white women. In New York, 50% of the people of color with lupus develop lupus kidney disease compared to that of 25% of whites. What was interesting in the data that I presented in your exhibits is that out of the 1,555 total visits that were the emergency visits of the data that was presented, 89% were in Clark County, 82% of 739 individuals were admissioned, and they were Clark County residents, which says that this is a predominant activity that's happening in the South, and it is one that we need to track and one that we need to find out, other than walking into the emergency room, what are the variants that are associated with lupus, and we need to track it, and we need to become a part of the access to care for these individuals who are becoming invisible within our society, will have been invisible within our society. So I wanted to give you guys that breakdown to just kind of, I guess, build a framework of what this is, why lupus is important, because it is a disease that is affecting thousands of people. The data that's in the record on the emergency visits is not a clear indication of who is going just for simple physician visits. So before I get into the bill, I want to introduce Miss Calvina Williams. Is it Calvina? Yeah. She is the president of the Nevada chapter of the Lupus Organization. Miss Calvina.
Hi. Thank you, Senator Neal. How are you? And how's everyone on there? Well, let me introduce myself. I am Calvinia Williams, founder and president of Lupus of Nevada. The mission of Lupus of Nevada is educational awareness and advocacy. For the last 17 years, our programs have consisted of nutritional workshops, monthly support group meetings, coping strategies, educational conferences, community outreach, and resources to assist our lupus communities. Individuals diagnosed with lupus have many obstacles. Some of our families and friends in the world around us choose to blame us for pretending to have lupus or its symptoms. Unfortunately, they are not aware of the impact and of this devastating disease. So they choose to look the other way or say out of sight, out of mind. My story is this. I am a lupus survivor of 20 years. My daily meds are 28 pills a day just to survive. Years ago, my dad and my son noticed it was hard for me to understand words. So my son, who was 10, would go with me to help me understand what the doctor was saying. I could hear my son saying, why is my mother not communicating? The doctor responded, she'll be all right. That's just lupus. It'll wear off. Side note, this is associated with a cognitive dysfunction with people who have lupus. It is called, in short, brain fog. A few weeks later, a new doctor was filling in for my regular doctor while he was out of town. While in the room, I started mumbling and sliding off the chair. He called his nurse and he said, this appears she's having a stroke. I was immediately taken to the hospital. I laid on a gurney in the ER hallway. Two doctors approached and read the notes from the triage. They were preparing me for it's a clot bursting drug to break up blood clots for stroke victims. The head doctor in ER happened to be scheduled on staff that evening, and he heard there was a possible stroke patient with lupus and other life-threatening health problems associated with lupus. The head ER doctor asked the other two docs, what are you doing? Don't inject anything in this patient. She has lupus. He explained, lupus is the great imitator. I don't believe she has had a stroke. Let's run some tests to determine the problem. Wow. I was misdiagnosed. Can you imagine if that head doctor in ER had not been there? What would have happened to me, the outcome? I believe that ER doctor saved my life. Let me leave you with a thought. How many more lupus lives have been misdiagnosed and didn't make it? For those reasons, please pass SB 175. Thank you for your time.
Thank you, Ms. Williams. We appreciate you making the time to spend with us to share your story.
Thank you.
Senator Neal.
Thank you. So I had two other presenters, Mrs. Bailey. She's also a part of the Nevada Lupus group. Miss Bailey. Can you unmute?
We see you, Miss Bailey, but we need you to come off of mute. Is there a microphone button that you can see on your screen?
Okay, I'm sorry.
There you go.
Can you hear me now?
Yes, we can. Please
Hello.
go ahead.
My name is Chaplain Wanda Bailey Johnson, and I'm the Director of Outreach for Lupus of Nevada. First of all, I had a problem with my pain center doctor. They had a procedure that they did on my lower back, and that became infected. Okay, what I was told was that I had something called Pseudomonas aeruginosa. I'm going to just spell the word because it's a medical word and I cannot pronounce it. The first word is Pseudomonas. Second word is Aeruginosa. Medical term. But now what I did, this is the problem that they told me that I had, and it came from the use of a unclean tool or equipment in the hospital. And it says also, when I did more research on it, it says from my research that I found, it was the way that I got it was through unclean hospital or person or persons going from hospital place to place. And I was sent to at least 5 different hospitals, different places myself, doctor offices. And I've been getting, I was supposed to have been getting a neural stimulator. This is for my back to stimulate the pain. Okay, now it was supposed to help me with my pain, but it was burning. It was burning inside my back. So it was something like that. So it took them about 3 months to finally they would change my bandage every day for 3 months. And then after changing my bandage every day, it took, wait a minute, sorry about that. It was to clear it up. This is one of the main reasons this SB 175 bill is needed so much to help us not just become, just to be used as guinea pigs, because it felt like that's what I was being used as. And then also, as we went on, the procedure, to getting the right procedures, so we can always get our right procedures, what we need done, so they can be accountable for it. And then say things that we do for people with lupus, and having the doctor to be accountable for what they do and what they give to lupus patients, and not just tell us, oh, it's just a lupus flare-up. About a year ago, I was in the hospital, and one of the main medications they gave me was 1,000 milligrams of prednisone for about 3 to 4 days, and they dropped it down to 80 milligrams, and then they sent me home. So I was very messed up for a while, and I went to my primary doctor, and she said, oh, that could have killed you. And she said, you don't supposed to drop down from 1,000 milligrams all the way to 80 milligrams, just like that. She said, you have to be weaned off and come down slowly off of prednisone. Okay, it took her weeks to get me back to my right amount for the lupus to get right. Okay, now this bill, SB 175 bill, would make the doctors be accountable for giving lupus patients the right medication. So let's do the right thing for all lupus patients all over Nevada. We thank you so much for your time, and let's just let Bill BS 175, let it pass. Thank you so much.
Thank you, Ms. Bailey. We appreciate you.
Yes. Thank you.
All right, so and one last person, Mrs. Sheehan. It's Sheehan.
Hi, can you hear me okay?
Yes.
Give me 1 second.
If you could introduce yourself for the record, that would be great.
Right. My name is Shan Clemens Ojeda, ShaAnClementsOjeda. I'm an executive board member of the NSDP, and I'm 27 years old. I was diagnosed with lupus when I was 9, and I'm on dialysis while I'm on my way to get on the transplant list. I'm in full support of SB 175 because not only do we need more research, information, and statistics to help find better treatments and more resources, we also need to hold our doctors accountable. Being diagnosed so young was a very lucky thing. The pediatric world is way more attentive than the adult medical world. Because of that, I knew what a good doctor or nurse was. So when I became an adult, I came across someone like this nurse in the ER. I was angry and shocked, to say the least. I came in with chest pain, severe heartburn, high heart rate, and a sore left arm. I had never sat in the ER for 2 hours without any of my vitals taken or EKG with such symptoms. I kept asking this nurse when someone was going to take my vitals and an EKG. She kept telling me soon. Finally, after sitting there for hours more with my ex, I demanded to know why I still hadn't had my vitals taken and still no EKG. I had all symptoms of a possible heart attack, and not to mention my family had a pretty severe heart disease history young. I knew not to take these symptoms lightly. This nurse sat down next to me and started rubbing my left arm that I had been holding and told her was in severe pain. She started to explain to me how the demographics worked, that patients that are older and more predisposed to deadly issues would go first, and that age and other things were factors to my long wait. I then explained to her that I fully understood the demographics and that any patient of any age coming in with chest pains of any sort and head injuries take precedence after fatal bleeding wounds, and that if she continued to say otherwise, she would be facing EMTALA violations for this hospital. Almost immediately after saying this, did I finally get my vitals and EKG taken. I eventually found out it was pericarditis, which is inflammation of the lining of your heart, a very common and luckily not deadly symptom of lupus, but it sure hurts like you're having a heart attack. Lastly, you need to know about the severity of lupus and how it's different for every patient. You can be like my friend Sam, who has painful but less deadly symptoms. You can have the severity of these two women speaking here with me today. You have me, a 27-year-old on dialysis who almost died 3 different times in her life. And then you have my mom. She was not only misdiagnosed as a paranoid schizophrenic and actually had lupus erythematosus her whole life, but she also died not long after being diagnosed while on the dialysis machine. She had died from heart failure. If not for a doctor in the psychiatric hospital she was in, didn't recognize, if a doctor in the hospital she was in didn't recognize her as someone that she had grown up with and knew about me, none of us would have even known that she had lupus, nor would we have known that she could have possibly been causing my mother's psychosis her whole life, and never able to raise her kids that she desperately wanted to do since before I was born as her first child. Maybe if we had more information regarding lupus patients in specific states like here in Nevada, maybe doctors would have caught that sooner. Maybe I would have had a mom as my mom instead of vague memories of her being unstable and dangerous and scared of the world her whole life due to living in a false reality, which was only a symptom. Her case should be recorded and looked into, and so should mine as every other lupus patient living in this state. Thank you very much.
Thank you. Appreciate you, Ms. Clemens Ojeda, spending your time with us this afternoon.
Thank you, Chair Ratty, for allowing those 3 presenters. There's a reason why I asked the 3 women to come on and present 3 different stories about how they've been affected, because that gets us into SB 175. If you get into, and I'm going to just jump right in Section 5, and the reason why this bill is necessary is because we need to collect data around the women. If you go to Section 5 of the bill, being able to establish a system where in Section 5(2)(a), where we can conduct comprehensive epidemiologic surveys of lupus and its variants and evaluate the appropriateness and the measures for treatment of lupus and its variants, that will help tell the story, number one, within the healthcare setting of what is going on. We need to understand what's happening because the disease mimics other diseases. We need to be able to have enough data and enough education for physicians so that they do not continue to misdiagnose lupus patients. In Section 6 of the bill, it continues to prescribe the kind of information that we need to seek within this framework. The variant for the lupus, the method of treatment without limitation, the kind of drug, and any other diseases in which the patient suffers, and information concerning the usage and access to healthcare services. If a patient is diagnosed with lupus and they die, we need to know what happened and how they died. When we listened to the story by Ms. Clement, her mother being misdiagnosed, knowing that there was a cognitive variant to lupus, would have helped her get the treatment early on. What happened with Miss Calvinia Williams, them misdiagnosing a stroke when she truly had a symptom of lupus, is something that probably could have happened to thousands of women, but we don't know because there could have been a doctor who said she was having a stroke, given them some medication for a stroke, and then effectively killed a patient. So I thought this bill was important. When they approached me about doing this legislation, I said, sure. And so the bill mimics a bill that I had in prior session around sickle cell, but basically Nevada needs to get into the game of being a part of the registry and collecting data. We fall in line with the national recommendations from 2015 from the Division of Health and Human Services And so this bill doesn't fall out of the general guidelines of what is being expected to put the first step forward to start collecting the data around patients and have it housed and collected and recorded so that we can understand what's going on with these patients. So pretty much that's in a nutshell what the bill does. The rest of the bill basically just explains the analysis and the confidentiality provisions of these kinds of reports that will be collected. And so I will open myself up for questions.
Thank you, Senator. Committee, questions?
Madam Chair.
Senator Keycover.
Thank you, Madam Chair. I notice that there's might be a more appropriate question in a finance committee, but there's no fiscal note attached to it. I do recall when that we had issues with the state cancer registry, right? When we were trying to assess fees on the providers to report data back to the cancer registry, it became a pretty significant financial burden on small doctors' offices and things like that, and it actually impeded some of the collection of data and information. So I'm trying to figure out in sections, I think 7 and 8, where along the diagnosis and treatment spectrum are people going to be assessed the fees for collection, and who's going to be required to turn it over?
So majority of the patients, from my understanding, see rheumatologists in the state. And so I believe when I spoke to Ms. Williams and the women, Ms. Bailey and Ms. Clements, there are roughly about 13 to 14 rheumatologists that focus on the autoimmune disease portion of this. The other entities that would be affected would be potentially the hospitals, right? The emergency room that is seeing the patient and then transmitting that information back. If they have a primary care physician, then that primary care physician would also be looped into this. The provision in the bill is similar to a provision that I had in a prior bill on sickle cell, where that fee was assessed. And I do recall those conversations in ways on the assembly side, but this has been the mechanism in order to get this information reported, is to place the onus on the actual entity that is treating the individual.
Yeah, I think you hit on a point that I was going to get to. We have a massive shortage of rheumatologists in the state, I think, and the financial onus of the state's work in this space being placed on a really small number of providers, I think could be problematic. And I don't know exactly, and maybe the division's available to talk about what it means. I don't know the workload of what would go into collecting, a single patient's files from multiple providers, from a hospital, from a rheumatologist, from a primary care doc, and then creating an abstract for each one of those patients. It seems like an awful lot of work to me. I worry about what those fees might have to be set at to cover the cost of doing something. So,
Senator Keycover, we have Lindsay Kinsinger from the Department of Public and Behavioral Health. I will say that the fiscal note has not dropped yet. The deadline hasn't passed, but they have done some work on it. So we will ask Ms. Kinsinger to answer your questions.
Yes, thank you. So Lindsay Kinsinger, Manager of Office of Public Health Investigations and Epidemiology, for the record.
Ms. Kinsinger, we're having just a little bit of a hard time hearing you. Could you just lean in a little bit?
Yes, sorry, can you hear me now?
That's a little bit better.
Okay, thank you. So we believe it would cost one full-time FTE to do this work. So one full-time person within the OP office to manage this registry, work on the fee structure, abstract the data, and collect the data, put it into our system, and then develop the reporting.
Okay. So do you have an estimate as to what the fee would have to be for each of the files, do you think, to generate that kind of revenue based on estimated patients and all that sort of stuff?
So we think it would cost us about $112,000 a year for this person and the abstraction and the reporting. I do not know how many rheumatologists there are across the state, and I don't know how that would break down. I am not fully aware of at what levels in each medical provider's office this data is collected. So this person would also be charged with that feat of, doing the fee structure and who would pay what.
I appreciate that, Ms. Kinzinger, and I certainly appreciate the need for collecting this information and using it appropriately. I worry that maybe this structure isn't gonna get us exactly what we're looking for. I appreciate it. Thank you.
Thank you.
Senator Dina Neal, for the record, thank you for the question. Because I understand that there is going to be a cost associated with this. I mean, I talked to the division so we could work out having the one FTE. This bill mimics another bill that I had on sickle cell. And so sometimes, you have to make the first step because there are individuals who are being faced with serious consequences of having an invisible disease. And when I've looked at other states who have, number one, passed legislation, it's been far and few between. California attempted to pass legislation twice. It hasn't made it out. Georgia has managed to get a commission on lupus. Illinois is the only state that I've seen that actually passed an actual bill around lupus for individuals. Nevada is one of those states where I feel like if $112,000 will save 10,000 women lives from being misdiagnosed and having enough data for us to get involved in the national space, get involved in the space of the funding, number one, because the federal government did the 8.5 million, but the total amount that came out of Congress in 2020 was $21.5 million. 10 million went to lupus research, 2 million went to Office of Minority Health, and 9.5 million went to the National Lupus Patient Registry. So there is an opportunity, number one, if we pass this legislation, to number one, engage in grants, engage in connecting ourselves from state to federal so that we can access funding. We currently don't even have a framework to even put our baby toe into the lupus registry nationally because we don't have legislation that is even asking for surveillance data around these patients. And so I understand the cost, but I also understand that even if this bill was able to get a one-shot chance of getting $112,000, we could potentially walk into an environment where we would leverage and be able to leverage ourselves for federal dollars that are in the space because of the recent funding that just occurred in 2020 under a Republican president.
Yeah, Madam Chair, I certainly appreciate that, and my suggestion is more that if we want to prioritize it, let's find $250,000 and just do it, rather than trying to create this funding mechanism.
Yeah, I think the suggestion is take out the fee structure. All right, Senator Spearman.
Thank you, Madam Chair. So, Senator Neal, this is a disease that impacts mostly women.
Yes. Majority of women, 90% of the lupus patients happen to be women.
So, do you happen to know what percentage of them are living in BIPOC communities?
Yes, in Nevada, based on the data, and I can do the national, but based on the hospitalization data that we have, which is in your exhibits, Black women represented 23.9% of the hospitalizations. Asian was 0.3%, Hispanic 3.3, and Native American was 5.7, and white non-Hispanic was 4.4%.
So here's, I guess this is maybe a statement part question. But over the last year or so, I think the last number that I saw was 300,000 Nevadans had been impacted by COVID, and more than 5,000. But I think lupus is a comorbidity when you start talking about diseases that epidemiologists track. Am I correct?
I don't know if they're tracking the comorbidity. That's the data that I'm trying to get. What I do have are the deaths. So there were roughly 133 lupus-related deaths between 2017 and 2020. And that was a rate of 1.1 per 100,000 in Nevada. Approximately 83% of the 133 deaths were female, 44% were white non-Hispanic, and 23% were Black non-Hispanic. And that was based on the ICD-10 codes that the division was able to pull for me in the summer.
And so I just asked that question because if it indeed is one of the comorbidities, I know, mostly they talked about asthma, high blood pressure, diabetes, but I would think that an autoimmune disease would probably qualify as a comorbidity. Having said that, the question is, what funding is available either at the state level or at the federal level to address this issue? Because I was listening to a report the other day, I think it was PBS, and the question is not if we'll have another pandemic, it's when. And so if we don't shore up those communities that are more susceptible to these sorts of things, we'll see more infections and we'll see more deaths. It's just a fact of life. So the question that I would have, and maybe you can't answer this, I don't know, Chair Ratty, maybe you have insight on this, but what money is available at the state level? What has come in for COVID relief and COVID relief as it relates to medical either diagnoses or prevention? Because certainly lupus is one of those things that mimicking other diseases puts you at a greater risk of not just a misdiagnosis, but as we heard from, is it Cheyenne? As we heard from her, it's not just a misdiagnosis, but you pay for it with your life.
Thank you, Senator Spearman. I don't believe we have anybody on the call with us today who can talk about all of the funding that has come in from the stimulus money to address COVID specifically, which I think was your question. And Ms. Clements Ojeda, so we're in the portion of the hearing where the senators have the opportunity to ask the sponsor questions. And if the sponsor wants to refer to you to answer a question, she can, but I won't be able to call on you otherwise. So I appreciate you want to jump into the conversation, but we've sort of moved back past that part of the process. I apologize. But certainly, Senator Neal, if you want support from any of your presenters to answer a question, that is at your discretion. But I think your point's made, Senator Spearman, that the COVID pandemic has shown a spotlight on the disproportionate impact of many parts of our healthcare system on people of color, and that the ask here is modest to be able to address a specific disease that disproportionately affects women and disproportionately affects people of color. I just don't think I can get you an answer to that question in this hearing. So with that, members of the committee, do we have any additional questions? Okay, so Senator Neal, just getting very much into the details of the money piece. So I want to make sure, so what I'm seeing is in section 7, sub 3, that the State Board of Health shall by regulation adopt a schedule of fees which must be assessed on a healthcare facility for each case from which the information is abstracted by the division pursuant to subsection 2. And so I think the question is, if there were, are you committed to a fee structure under which the facilities pay part of the weight, if you will, to be able to collect this information? Or if there was a general fund appropriation available, is that okay? I mean, as the sponsor of the bill, do you care how it gets paid for, or is that an issue for you?
So thank you for the question, Senator Ratty. That's not an issue, but to amend that out would be the gamble that we're going to find the $112,000 going through Senate Finance to fund the mechanism if it was removed. So I don't care how it gets funded. I think that if we do this, we position ourselves for the federal money that comes available in the future to help the research and develop this further. Right now, we have nothing, no part of the landscape of lupus. Not our state next door to us, not the states around us. So we would be putting a step forward to say that at least in the western side of the United States, we want to help lupus patients. So if you guys find it in your great wisdom to remove that fee structure and think that you can finagle $112,000, I'd be open to it.
Well, certainly as the sponsor of the bill, Senator Neal, I'm gonna leave those decisions to you. You understand this process probably better than many other folks in the building. So I know you are, we'll give some thought to that. I just want to make sure we're clear on it. And it seems like there's another fee in section 8, sub 2, sub B that is about anybody who wants to do research with the data. But we don't have the fiscal note yet, and this is a policy committee. So really today we're focusing on the merits of the policy, and the decision before the committee will be about the merits of the policy in terms of collecting this information. Either way, it'll get kicked to finance if it comes out of our committee for the finance discussion. So with that, committee members, do we have any other questions? Okay. Seeing none, let's go ahead. Oh, sorry, I missed you, Senator Hardy. Go for it.
Thank you, Madam Chair. You know, as I'm reading the bill, I think the $112,000 for full-time is for the person who's in charge of putting it together by the state. Yet the sections 5 and 6 require hospitals, medical laboratories, other facilities, providers of healthcare to report. I think the bulk of the financial burden is probably not going to be, as I look at it, under the state, but the people who are trying to report all this and the extent of the reporting form and matter in which it's done, and then making sure that that is compatible with HIPAA, so that names, ages, etc., are not shared. So I think it's problematic from not just the state, but from the industry in toto. Who reported it, who didn't report it, when they did it, and so I think when we start looking at section 6, line 18, the name, address, age, and ethnicity, you know, those are pretty sensitive things that we're trying to figure out how to report and how to deal with. So I have challenges in the logistics of it. And, you know, if I start looking at other diseases like diabetes or, you know, et cetera, but I just don't feel as comfortable as I would like at this point.
So,
Senator, before you go, Senator Neal, is there a question in there, Senator Hardy, or just a comment?
It's one big question. How do you do it?
Okay. And I appreciate that question. Thank you, Senator Hardy. So if you go to section 11, this is information that goes from the care facility to the division. And in section 11, you have the shall not reveal the identity of the patient, physician, or healthcare facility. And then in section 12, you have the confidentiality provisions, which talks about they must not be liable in civil or criminal action for sharing confidential information unless it was done in bad faith or for malicious purpose. This language is actually very similar to language that I had in a bill in 2019 on sickle cell. And these provisions seem to pass the legislative muster to make sure that the two-way street between the provider and the division, which is who wants this information or who I'm designating in this legislation to get this information, is not going to reveal that information. This is not going to become public information where then you pull up a database and then you see Melissa Jones that went to Sunrise Hospital. That is not the intent, nor is that what Section 11 says or spells out. And in the prior situation of the bill that I had around sickle cell that had exactly the same provisions that was passed out and signed by the governor, there has been no confidentiality breaks with the same exact language that you see in Section 11 and Section 12.
Thank you, Senator. Okay. Any additional questions? All right, with that, we're going to go ahead and open up the testimony lines. So for BPS, would you go ahead and open up the phone for anybody who would like to testify in support? And please limit it to 2 minutes.
Thank you, Chair. Callers, if you'd like to testify in support of Senate Bill 175, please press *9 now to enter your place to the queue. Once again, *9 now to testify in support of the bill. Will the caller with the last 3 digits of 855 please slowly state and spell your name for the record? You'll have 2 minutes and may begin now.
Hi, my name is Samantha Wayne, SAMANTHA WAYNE. So my name is Samantha Wayne, and I have been living with lupus for 14 years. I am in support of SB 175. I can't tell you how many times I've visited a doctor for a cold or infection, and they are hesitant to treat me. I'm then forced to turn to my rheumatologist, who won't treat me for anything but my lupus. You can see how a chain of information about lupus patients can make a huge difference in the care of a lupus patient. In 2017, I had to go to the hospital for extreme chest pain, and I had trouble breathing. I waited hours in the hospital bed before they decided to treat me with ibuprofen. It was clear to me that it seemed like I was just another patient looking for pain meds, rather than a 24-year-old in extreme pain. So instead, I went home with temporary pain relief and a $700 hospital bill. In 2018, I ended up in the hospital again after developing autoimmune hemolytic anemia, which is a rare blood disorder that can occur with lupus. My body was attacking my red blood cells, causing them to become dangerously low. The doctors were fearful of giving me a blood transfusion because the lupus would continue to attack the new blood cells, and they were unsure of how to treat me. I have been advocating for lupus since I was 15. Early on, I saw the gap in treatment and awareness. More research and data is important to improve the care of thousands of Nevadans living with lupus every day. Thank you.
Thank you.
Will the next caller with the last 3 digits of 505 please slowly state and spell your name for the record? If you're having trouble unmuting yourself, you can press *6 and you will have 2 minutes. You may begin now.
Hi, my name is Tasha Pittman,
Tango Alpha Sierra Hotel Echo Papa India Tango Tango Mike Alpha November. I'm a technical sergeant, retired veteran from Nellis Air Force Base. I was diagnosed with lupus in 2010. I've been going as a medical mystery since I got here in 2004 with the symptoms of breaking out from the sun, allergic to sunscreen, rapid heart rate, not knowing if it's a stroke or heart attack. The doctors sending me downtown because they didn't have doctors on base. So I've been like in between doctors because most of the medical doctors are actual medical students or people that are in the military. So most of the time my appointments are pushed downtown. So the only problem that I notice is that going to the emergency room, you have to get referrals from them, and they have to state it's for lupus, but they don't know exactly what your symptoms are. So most of the time I'm just getting the diagnosis, oh, it's your lupus, so just go see your rheumatologist. So that research would be vital for people in the military or people who don't know, who didn't grow up and find out earlier in life that they were diagnosed with lupus. That information would be vital to pass this bill. And I'm in support. Thank you.
Thank you. Thank you.
Callers, if you're just now joining us, we are on support for Senate Bill 175. If you'd like to testify for support, please press *9 now to enter the queue. Chair, at this time, it appears no more callers are wishing to testify in support of the bill.
Thank you, PPS. If we could go ahead and open up those who would like to testify in opposition to SB 175.
Certainly, Chair. Callers, if you'd like to testify in opposition to Senate Bill 175, please press *9 now to enter the queue. Once again, we are on opposition. Please press *9 now. Chair, at this time, it appears no callers are wishing to testify in opposition to the bill.
Thank you, PPS. And could we go ahead and open up the testimony in neutral on SB 175 with a limit of 2 minutes?
Callers, if you'd like to testify in a neutral position for Senate Bill 175, please press *9 now to enter the queue. Once again, that is *9 now to enter the queue for a neutral testimony. Chair, it appears no callers are wishing to testify in a neutral position for the bill either.
Thank you, PPS, for your support. All right, we're going to go ahead and take it back to the sponsor for closing comments. Senator Neal, would you mind just quickly explaining the amendment to SB 175 so that we have it on the record before you do your closing remarks?
Thank you, Chair Ratty. I did forget about it. So basically, the amendment of the bill is really simple. It would require DHHS to coordinate with the National Lupus Patient Registry and include in the list of purposes for which DHS must apply for and accept any gifts, grants, and donations in Section 10 to coordinate with the National Lupus Registry. And the purpose of that amendment is I want to put DHHS in a position to leverage themselves to go after federal funds. Since we're not a part of the lupus registry. And I believe that if we become a part of it, if we pass legislation to start the surveillance projects that have been going on since 2004, that we can position ourselves to start asking for grants, really applying for grants to help move this agenda forward around lupus patients.
Thank you, Senator Neal, and thank you for bringing the bill. We'll just give the committee one last chance to see if there are any clarifying questions on this bill.
Yes.
Senator Spearman?
Thank you, Madam Chair. So the issue is about the money. I'm wondering if it's possible to add as money becomes available. Would that still put DHHS into a position to go after grants, et cetera?
Thank you, Senator Spearman. I believe so, as long as the provision in the back of the bill allowed them to still go after grants, donations, etc. I have seen that language get practical. So I believe in this policy. It's a good policy, but whatever the wishes of this committee, I've had I'm sorry that, I've had a super crazy headache all day. But hopefully, the committee can find support to at least get the policy out, to put a first step forward, to maybe allow it to go to finance to find money, or put that money in as money becomes available. And I thank the committee for the questions.
Thank you, Senator. To you, Senator Spearman, or Vice Chair Spearman, if you look at page 5, section 10, it actually says the division shall apply. So it directs the Department of DHHS to apply for and accept any gifts or grants specifically to support this project.
Yeah, I saw that, but it seemed like the issue was the money. So I was just trying to figure out a way that we can make sure that it's strong enough to survive, and then whatever gifts or grants that are out there, they can still go for. Because I don't want us to, if we have that opportunity, then money is, but it isn't an issue.
So I appreciate the comments. I'll just remind everybody, and for those of us who may on the call who may not regularly participate in legislative process, which can be sometimes a little bit arcane and hard to follow. This is a policy committee, so this committee will make a decision based on the merits of the policy. Because it has financial implications, what will happen then is that if it passes out of this committee, it will get picked up by the Finance Committee, and there'll be another opportunity for another conversation to talk about the money. So we'll be focused on policy here. I also want to make sure that the folks who are on the call who may not have participated in something like this before know that we don't vote on the bill today. So by legislative rules, there has to be some separation typically between the time we hear the bill and the time we vote on the bill. So I apologize, but you won't have the satisfaction of knowing how it all turns out today. That'll happen at a future committee meeting on a work session. So with that, I'm going to go ahead and close the hearing on SB 175. Thank Senator Neal for her presentation and express my hope that she's going to be feeling better soon. And we'll go ahead and move on to Senate Bill 251. So I'd like to open the hearing on Senate Bill 251 and invite Senator Sievers-Gansert to the virtual podium to present the bill. If you were here for Senate Bill 175, we will not be conducting any other business on that bill, and you are free to log off if you'd like.
Thank you, Chair Ratty and members of the committee. For the record, my name is Senator Heidi Sievers-Gansert. I'm the senator from District 15 in Northern Nevada. Today, I am joined by Dr. Nathan Slotnick. Dr. Slotnick is a medical geneticist and a high-risk obstetrician. He has been practicing or seeing patients in Nevada since 1990. In 2005, he was asked to start a cancer genetics program by a local oncology practitioner group. He's also been part of a high-risk pregnancy practice with over 50,000 patients. He has been faculty at the University of Nevada, Reno School of Medicine. And in 2020, he was named the medical director for reproductive genetic medicine at Invitae Corporation. I'm also joined by my friend, Abby Whitaker. Abby is a well-respected and award-winning communication specialist and entrepreneur. She and her husband founded the Abby Agency. The Abby Agency's tagline is where chutzpah meets acumen, which accurately describes her. So I'm really happy that she could join us today. Generally, this bill is about raising awareness and increasing appropriate screening for the most common cause of hereditary breast cancer. That would be inherited mutations of breast cancer genes, also known as BRCA1 and BRCA2. Since we have Dr. Slotnick with us today, I'm going to let him cover that. And then Abby is going to tell her story. And the reason I brought this bill was Abby gave me a call several months ago to let me know that she was BRCA positive. And she asked if we could do anything about it and to make sure there's more awareness and make sure women get screened if appropriate. And I thought that we could do that. And it also brought to mind that within the last 5 years, I probably have a half dozen friends who I personally know who've been diagnosed as BRCA positive. And Dr. Slotnick will be able to explain the high risk of cancer if you are BRCA positive. And the common thread with all my friends is they had been fighting cancer for a while, and many of them were diagnosed at an early age, but the dots were never connected that they may have had a hereditary mutation. And the reason it matters if you have the BRCA genes, it matters for the woman herself, but also for her children because it is hereditary. So I've had friends, I've had a member of my family affected by this, and some have children who have been BRCA positive and some have been negative. But the key that we need to remember is that you have to be able to get a screening and a referral for counseling and then testing. So I'd like Dr. Slotnick to start and then have Abby talk about her personal story, and then I'll run through the bill if that's okay with you, Chair Ratty.
Please proceed.
Thank you. Dr. Slotnick?
Thank you very much. I very much appreciate the invitation to speak with you today. But before I make sure that I compliment Senator Sievers about Sievers-Ganser, sorry, to have the energy and the foresight to be able to put together the presentation today. It is her energy that really allows me the honor of speaking to you today. So my name is Nathan Slotnick. I'm a medical geneticist, and today we're going to talk about an increasingly important component of cancer care, a subset of medical genetics, which is what I do. In order to present this information to you in a comprehensive kind of way, I'd like to start with a bit of background. Now, we are what we are because of what we inherit from our parents. Our parents give us instructions that tell the cells of our body how to behave. Those instructions tell brain cells to become brain cells and liver cells to become liver cells. The instructions are called genes. The genes are made of a chemical called DNA, and the DNA is included within the cells of our body. Now, each human adult has in their body approximately 30 trillion cells. All of those cells are the result of many, 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 many cell divisions from a single fertilized egg. Every time a cell divides, errors can occur. And when those errors occur, they can accumulate. And if those errors accumulate in some of the control genes of the cell, one of the possible results is cancer. What
So, Dr. Slotnick, I'm going to ask you to pause for a minute and just let me check in. Other members of the committee, are you having a hard time hearing Dr. Slotnick? Or is it just me?
I can't hear a thing.
So, BPS, can you help me? Is everybody having a hard time hearing Dr. Slotnick, or is it just me?
Hi, Chair. This is Kayleen. Do I have permission to interrupt and help?
Yes, please.
Okay, Mr. Slotnick, the connection is kind of failing out right now, so we could try and connecting to your phone. Chair Ratty, did you want to take a break to figure this out, or did you want to continue?
So let's try one other thing. Perhaps Dr. Slotnick could turn off his camera. And sometimes when you're having some internet, slow internet problems, the turning off the video will free up the line. So could we try that first?
I will make an effort to do that. I'll have to restart my sharing. And so my video is now stopped.
Yes, it is. And your audio is significantly better.
Ah, well, let's hope that's satisfactory then.
We'll proceed.
So I will
Dr.
continue,
Slotnick,
and I'll try to speak more slowly.
Actually, no, I think you're fine. It was just slow internet, so I will interrupt you if we're having any problems, but please just feel free to go ahead.
Thank you very much. The point I'm trying to make in the slide is to say that cancer results from a change in the DNA of an individual cell, producing a control-less cell. And because of that, cancer can be considered as a genetic condition. So if that's the case, how can we get more information on that? And the answer comes to better understanding if we think about a specific form of cancer. The forms of cancer that I'll talk about now have to do with a condition called hereditary breast and ovarian cancer syndrome. This is a syndrome that was described 30 years ago now by some researchers in California and in Nevada, by the way, and results from a mutation in a particular gene called BRCA1 or BRCA2. This is a gene that has been appreciated for years, but its clinical impact has had an increasing appreciation over the years. If you're a woman and you have a mutation in BRCA1 or 2, the impact on your health is huge. By age 40, the average woman, 1 in 200 women will develop cancer. But if that woman had a mutation in BRCA1 or 2, the risk of cancer to her is anywhere from 10 to 20%. By age 50, 2% of the population of women will develop breast cancer. But if those women have mutations in BRCA1 or 2, that risk goes up to 33 to 50%. It's a huge impact on the population. Lifetime risks are affected too. 1 in 8 women will develop breast cancer during their lifetime, just in a population sense. But if you look at the carriers of BRCA1 or 2 mutations, you'll find that the risk of cancer for those patients is anywhere from 56 to 87%. But it doesn't stop there. It also influences the risk of developing ovarian cancer as well. About 1.8% of the female population will develop ovarian cancer during their lifetime. But if that patient has a mutation in BRCA1 or BRCA2, the numbers are remarkable. 44% of patients with BRCA1 mutations will develop ovarian cancer. 27% of patients with BRCA2 will develop ovarian cancer as well. If we look at all the genes related to breast and ovarian cancer, we'll find that the majority, 85%, are the results of mutations in one of these 2 genes. But there are many other genes as well. And to overlook those genes would be a mistake. So we are now offering genetic testing for many different genes, although our conversation today is focusing primarily on BRCA1 or 2. Again, it doesn't stop with just breast or ovarian cancer. If you have a patient with breast cancer, 5% risk, that patient will have a 5% risk of developing a second independent breast cancer within 5 years of the original diagnosis. But if that patient has a mutation in one of these 2 BRCA genes, the risk goes up to 12 to 20%. If you look at breast cancer over the lifetime of a patient, you'll find that the incidence of a second breast cancer goes up dramatically as well. So the influence is huge, not just on the original diagnosis of cancer, but also and ovarian cancer, but other cancers and second primaries as well. But it doesn't stop there. Males can get breast cancer as well, but but it's really, really rare. But if a male has a mutation in BRCA1 or 2 inherited from either parent, that male will have a 7% chance of developing breast cancer. The risks are increased for prostate cancer, for melanoma, and most importantly, for pancreatic cancer as well. And for those reasons, there are certain conditions for which testing for BRCA1 or 2 has been recommended and is now standard of care. For breast cancer under the age of 45, for ovarian cancer at any age, for pancreatic cancer at any age, and for certain forms of metastatic prostate cancer as well. So this is a condition that can influence the health of not just men and women, but whole populations can be affected as well. Why do we do it? Why do we test patients in anticipation of potential risk of cancer? Well, the answer is because we can do something about it. If you have a mutation in BRCA1 or 2, you know your risk of breast cancer is dramatically increased. But a medication as simple as something called tamoxifen will reduce the risk of breast cancer in a patient's lifetime by 50%. If you have a BRCA1 or 2 mutation and are worried about ovarian cancer, something as simple as ovarian contraceptives, birth control pills, can reduce risk of cancer too. Other things that can pop to the mind as being reasonable options include prophylactic surgical procedures, including prophylactic risk-reducing bilateral mastectomies, prophylactic bilateral salpingo-oophorectomies, or tube and ovary removal, and ovarian removal itself. All of these are surgical procedures which will reduce the risk of cancer for women dramatically. Now, if we think about breast cancer as a genetic condition, how does that happen? Well, on the left side of the screen, I don't have a pointer, but the left side of the screen, there is an indication of a particular error that occurs in DNA synthesis. That error is called a DNA double-stranded break. Every time that error occurs, a whole collection of different genes within the cell are called to account, and all of them get together in an attempt to repair that DNA double-stranded break. If the repair is successful, you'll see at the bottom of that image on the left side of the screen, the DNA has been repaired properly. But if there is a mutation in any one of these genes, including BRCA1 or BRCA2, which are right in the center part of this image, the repair system is less functional, repairs don't occur as regularly, and those errors accumulate and can be related directly to the incidence of cancer. Now, why are we able to say all this? Well, the answer is that we've gotten very, very good at sequencing DNA. We can now sequence DNA from a single cell. We could look for specific gene alterations that might be related, and the cost of DNA sequencing has dramatically reduced. So in summary, what we're talking about here is the ability to identify patients at risk for carrying a mutation that might be related to their own cancer or to the cancer risk of later in their life, and for the risk to their family. So for that reason, considering cancer risk and considering testing should be part of every patient's assessment. Anytime a patient is seen by a doctor, there should be a discussion of family history and personal history. And if the clinician perceives a need to move toward testing for BRCA1 or 2 mutations, that should be encouraged and is something that can have a huge impact on the health of women and men of the state of Nevada. Thank you very much.
Thank you, Dr. Slotnick. Chair Ratty, I didn't know if you wanted to open up for questions, so technical questions for Dr. Slotnick, or you wanted to go forward with Abby Whitaker.
Well, I would hate to make everybody wait for the phenomenal Abby Whitaker. However, why don't we go ahead and just see if there are any technical questions on the bill, and then we'll be able to wrap up with that. Senators, do you have any questions for Dr. Slotnick on the more clinical aspects of what we're talking about? Right. Dr. Slotnick, it looks like you're getting off easy today. So thank you for being here to present with us. Why don't we go ahead and turn it over to Ms. Whitaker to share your testimony.
Hello.
Thank you very much.
Can everyone hear me? Awesome. I'm sitting in a state park in Ely, Nevada, so I was hoping I would have good cell reception. My name is Abby Whitaker. I am 45 years old, and I have tested positive for BRCA2. I've been getting mammograms for the last 5 years, and then this year I switched to Reno Diagnostic Center. Before my mammogram, they had me fill out a questionnaire asking some questions about my family history, et cetera, et cetera. And when I went in for my mammogram, they said that I'd been flagged to potentially take a free genetic test. And I was like, you sure it's free? I'm only taking it if it's free. I don't want to pay for it. And they're like, no, it's free. So I took the genetic test, had my mammogram, kind of forgot about it. A few weeks later, I got a call from Amber Genetics to set an appointment to talk with me about my test. To be honest, I ignored it for about 6 weeks because I was too busy, as many of us are. And then they kept calling and calling. I'm like, I should probably talk to this genetic counselor. It sounds like it's important. They got me on the phone and they told me that I had tested positive for BRCA2. I didn't really understand what that was, and I didn't really know a lot about that. What they told me was that it would increase my risk over my lifetime from between 45 to 75% that I would develop breast cancer, and about, I think, 45% for ovarian cancer. I'm already a cancer survivor. I've already been through anal cancer and chemo and radiation, and never was I flagged for this type of genetic testing or flagged for BRCA. I go to the doctor all the time. I have so much blood work and so much stuff done to me. You'd think that maybe they would have caught this, but understandably, there's a lot of different things for a lot of different procedures. Thank gosh the Reno Diagnostic Center decided to ask me those questions, or that it's their policy to ask me those questions, because now I know. I have 8 brothers and sisters who are now all going through genetic testing to know if they too have BRCA2 or BRCA1. I have 10 cousins throughout the world who are also going through that testing, knowing that this came from my father's side. I have decided that on April 15th, I am having a bilateral double mastectomy, and then I'm going to have a hysterectomy after that. I am able to make that choice because Reno Diagnostic Center asked me some simple questions about my genetic history, and I was able to find out that I have BRCA2. As women, as mothers, as senators, as career people, we have so many things going on in our lives. And the fact that I now have this knowledge and that I can make that decision and that I can make sure that I don't die from this cancer, it's phenomenal. And I did approach Senator Gansert. It was like 5 a.m., I think, that I called her and I was like, hey, what can we do? What can we do? And she's like, you know what? We might be able to change the law so that there is more screening and that more women and men know this. So I just want to thank her and I know many of you have signed on as co-sponsors for this, and I appreciate it. You know, fighting cancer, battling cancer is something that none of us want to have to do. And if we have this knowledge, then we can stop it. We can stop it with my daughter, my son, your daughter, your son. And I think that is a wonderful opportunity. So thank you today for listening. Thank you, Dr. Slotnick. Thank you to everybody. I appreciate it.
Thank you, Ms. Whitaker. So Ms. Genser, do you want to take us through what the bill actually does?
Thank you. I want to thank Abby and Dr. Slotnick for being on the Zoom today.
Hold on for just a second.
Yeah, so
hold on for just a second. Senator Harris,
yeah.
I see you had your hand up. Did you want to ask a question of Ms. Whitaker?
No, I was going to ask a question to Senator Sievers Gansert, but I will wait until after she walks through the bill.
Okay.
Thank you.
Okay, thank you. What I'd actually like to do is start with an amendment that was posted, because this helps kind of simplify the process of going through the bill. So I've got a conceptual amendment that was posted a couple of days ago. And basically what it starts out to say is this is the screening and getting the counseling and referral for testing is actually covered under preventative services based on the United States Preventative Services Task Force, which means right now this is covered by the feds. It's required that insurance carriers cover, again, the screening, the referral for counseling, and potentially the testing. And you only go through the counseling and the testing if you've had this personal and family history done, which indicates that you're at higher risk. So you do that screening, which is super simple. Again, it's connecting the dots. And part of what Abby was talking about is, so when Dr. Slotnick mentioned if you have a cancer before the age of 45, certain types of cancers, then you should have been identified to be referred for counseling and then potentially genetic testing. And so even though she'd had that cancer, and even though she was getting mammograms, even though she was going to physicians, no one ever flagged her till she had a bit more thorough personal and family history taken by Reno Diagnostic Center. So that's part of the key, is the insurance, according to the federal law or federal code, is required if you are at higher risk, and then you get the referral and then potentially testing. And so that's what the amendment essentially says. And then, so if we would start to walk through the bill, that would have been part of Section 1. Section 2, what we did also is created a flag. So say that your practitioner doesn't do this screening. When you go get a mammogram, right now, you always get a patient will get a report back. And on that report, we have a notice. So Section 2, number 3 describes the notice. 10 to 20% of all cancers can be categorized as hereditary, and the clinical and financial value of identifying patients and families at risk is well documented. If you have a personal or family history of breast, ovarian, fallopian tube, peritoneal, or other cancer, please consult your physician regarding genetic counseling and testing. So that's a flag to make sure that just in going in for a mammogram, that we can raise the awareness. Then we can drop down to Section 3. Currently in statute in 457, which is the cancer statute, it talks about if you have violations of the statute, then eventually and convicted, if you would be guilty of a Category D felony. What we did is we actually exempted the practitioners from a Category D if they had not followed this. This is something new, and I don't think practitioners, if they don't follow this exactly, should be fall into a Category D felony. So anyway, that's what Section 3 does. Then we go on to, I can do from the beginning. Let's see, I marked it up. The exemption, then we go down to Sections 8 to 11, which basically allows that continuing education credits for work around genetics. So if you take a class on genetics, and when I talked to Dr. Slotnick offline, he talked about how genetics is really at the forefront of medicine, and we haven't had broad knowledge. And so this does not require continuing medical education around genetics, but it says it counts. So it counts down toward the requirement, no matter what kind of specialty you may be. And then if we go down to, just walking, let's see, the coverage, basically most of the body of the rest of the bill is taking and preserving the requirement that insurance covers, again, that screening, the referral for counseling, and then potentially the testing. And it doesn't require a woman or a man to get the testing, but it basically allows them to get it and have insurance coverage for that. And so the remainder of the bill really is about the different types of hospitals, network plans, insurance providers, and so forth, to codify in Nevada statute what is already required in federal statute. So that is the body of the bill. I have been contacted by some of the benefit providers, some of the insurance providers, and they asked in Section 24 that if this was to become effective, that it would be January 1st of 2022. So originally the bill has July 1st of 2021, but we were looking towards January 1st of 2022 so that they can update their plans and their benefits. And then the other thing that was considered is once you've actually taken a test, a genetic test, you don't necessarily need to repeat that. So we could also consider in this bill that once you've taken a test, that we don't have these requirements to continue the screening and the referrals because it's already been done. So that in general is the bill. And again, as was described by Dr. Slotnick, when you test positive for BRCA1 and 2, the odds of getting cancer are off the charts. Literally in your lifetime, it can be as high as 87%. I think we really need to raise awareness and increase the screening so that women, and all of the numbers are low, men know if they are at risk so that they can take appropriate actions. And as he mentioned, it could be pharmaceuticals, it could be surgery like Abby's going to go through. But what we want to do is make sure that people can stay as healthy as possible. And Abby mentioned her kids, her cousins, her siblings, because it is a hereditary mutation. I can tell you, I had a friend who died last year, and the entire time I knew her for 25 years, she was fighting cancer. And within the last 5 years, she tested positive for one of the BRCA genes, and she has 2 daughters and a son. Both daughters tested positive. The son was negative, and one of the daughters has already had a mastectomy, a double mastectomy, at the age of 30. I think she's 32 now, and then there's sort of a timeline, and that was based on counseling. So again, you have to decide with your physician what you're going to do. But in her case, and given the family history that she has, that was the decision was made. And then we'll have testimony, hopefully a little bit later, from a sister-in-law of mine, and she tested positive, and she'll tell you her story. But her kids both tested negative, thankfully. So it's one of those things. It's hereditary. We know how to diagnose and I guess test for this. So I really believe that we should be doing it because it can save lives. It's obvious it can save lives. So I thank you for your attention this evening, and I am open for questions.
I think Senator Harris had a question.
I did. Thank you, Chair Ratty, and I'm glad I waited until after the presentation. I really was appreciative of the exemption from the felony requirement. And so my question is there any kind of stick to this carrot to kind of encourage doctors to comply with the law?
Thank you, Senator Harris, for that question. Right now, I don't have a stick. This is something that's brand new. And, you know, when you think about when you go to the physician, they usually do a family history. They always do, but it's that connecting dots. And right now, there are tools that have been developed and that are being developed that make that really easy for practitioners. And that would be an MD, a DO, a nurse practitioner, several types of practitioners. So no, there's not a stick. But I really hope that this strongly encourages them. And I have been talking to the Medical Association, OBs, and so forth about this to try to get this implemented. So thank you.
Thank you. Senator Hardy.
Thank you, Madam Chair. As I read it, then the continuing medical education credits for genetic instruction can replace, stand in lieu of.
Senator Hardy, we're having a little bit of a hard time hearing you too. Could you lean in a little bit, perhaps?
So as I understand it, the CME requirements can replace or be in lieu of suicide, pain management, addiction, or the other requirements that physicians, whether MD or DO, are under a responsibility to have?
For the record, Senator Heidi Seifers answered, and it's not in replace of, it just allows them to count. So as you mentioned, there are certain categories that are required, but there's actually more CMEs required than are categorized, I believe. And so it's a choice that you can make, but you can get credit for genetic instruction.
Well, right now we can get credit for genetic instruction. The way I read it, it looks like it could replace or be in lieu of those other requirements, but that's not your intent.
No, the intent is not to replace one, it's to make it an option, because as you know, there's certain that are required. So you have a total number required and then certain categories that are required. And so this would not be a required category, but an acceptable category to fulfill part of the entire number that is in statute.
Right now, I don't know of any preclusion that would preclude you from counting genetic hours, but maybe that's my misunderstanding. Thank you.
Thank you.
Thank you, Senator Hardy. Additional questions? All right, let's go ahead and open up public testimony on Senate Bill 251. BPS will start with public testimony in support, limited to 2 minutes.
Thank you, Chair. Callers, if you'd like to testify in support of Senate Bill 251, please press star 9 now to enter the queue. Will the caller with the last 3 digits of 523 please slowly state and spell your name for the record? You'll have 2 minutes and may begin now.
Madam, this is Tom Clark. That's TomClark. I'm testifying today in support of the legislation on behalf of the Nevada Association of Health Plans. We want to thank the senator for bringing the bill and also thank her for working with us on the conceptual amendment that has been brought forward. This is a really important issue, and hopefully we can increase some awareness and get folks like my friend Abby assessed and tested. And thank you.
Thank you, Mr. Clark.
Will the next caller with the last 3 digits of 670 please slowly state and spell your name for the record? You'll have 2 minutes and may begin now.
For the record, Carrie Harrington, that's spelled CARIHERINGTON. I'm Executive Director for Nevada Cancer Coalition. Good afternoon, Chair Ratty and members of the committee. We thank Senator Sievers-Gansert for bringing this forward, and we support the intent of this bill to provide formal risk assessment for breast cancer and notification to women of her risk factors specific to the BRCA gene mutation. This follows legislation passed during the 2013 session to notify women with dense breast tissue, also a risk factor for breast cancer. The American Society of Breast Surgeons screening recommendations, which have been adopted by providers across our state as the most up-to-date and research-based recommendations, states women beginning at age 25 should undergo formal risk assessment for breast cancer, which may include genetic testing if indicated. Women identified at higher than average risk due to pathogenic mutation, a predicted lifetime risk of more than 20%, or strong family history are recommended to receive additional screening, which most often can be a yearly MRI or breast ultrasound. The ACA requires health insurance plans to provide coverage for mammography screening only once every 1 or 2 years for women over 40. However, if a woman has these risk factors for breast cancer, there is additional testing that could leave her with hundreds to thousands of dollars in out-of-pocket costs. While limited genetic testing is available for the BRCA gene mutation, it could give a sense of false hope for one's cancer risk by not including other known genes. Most patients should undergo a broader panel test, as Dr. Slocknet mentioned, which should be covered completely. While Nevada is making great strides in notifying and informing women of their increased risks and recommended cancer screenings, we need to ensure they are also provided the support, full genetic testing, and yearly screening options that are right for them, all without any out-of-pocket costs. Thank you very much.
Thank you.
Will the next caller with the last 3 digits of 018 please slowly state and spell your name for the record? You'll have 2 minutes and may begin now.
My name is George Ross, GeorgeRoss. I'm speaking on behalf of Comprehensive Cancer Centers of Nevada, the acronym CCCN. CCCN would like to thank Senator Sievers-Gansert for bringing forward this very important bill. I'm very much in favor of the bill and very much in favor of the conceptual amendment. We would request that when the final draft, when the draft of that conceptual amendment is ready, we'd like the opportunity to review it, because a word or a phrase which could be maybe slightly different than it could have been or should have been, will make quite a difference in how the bill is implemented. But beyond that, we just want to again go on record as saying this is a very important bill and thank the Senator very, very much.
Thank you.
Will the next caller with the last three digits of 136 please slowly state and spell your name for the record? You'll have 2 minutes and may begin now.
Hi, my name is Marian Gansert, Marian, last name Gansert. I am in support of SB 251. After listening to Abby Whitaker, my story is somewhat similar to hers in that I was never flagged during the course of my breast cancer history. It all started 36 years ago. In 1985, I was diagnosed with breast cancer on my left side. I had a mastectomy. I was 30 years old. I was told not much was known at that time about breast cancer. As years went by, I decided, well, I'm going to go ahead and have a mastectomy on my right side. I just wanted to be proactive, and so I had this preventative mastectomy done. In 2015, I went to my annual gynecology appointment, and my gynecologist said, hey, you're eligible for BRCA testing. Let's get you tested. I met criteria because I'd had breast cancer when I was 30 years old. My test came back positive. During that time, they said that if a woman tested positive for the BRCA2, she had a 50% chance of developing ovarian cancer, a 90% chance of developing breast cancer. Well, I jumped on it, and 2 months later, I had a total hysterectomy done, thinking that, well, I've had 2 mastectomies, one for breast cancer and the other one preventative. I thought, oh, right, I'm doing great. Well, it didn't turn out that way. In 2017, I was diagnosed with breast cancer on my preventative mastectomy side. I guess maybe a piece of breast tissue had been left behind. So anyway, I've had breast cancer on both sides over the last 36 years. I am BRCA2 positive. I have a son and daughter, and I was told it'd be 50-50 whether they carried that mutation. Both of them tested negative. As far as my family history goes, it's vague. My mother never had breast cancer to my knowledge, and I don't know of anyone on either side of the family, my mother or my father's side, having breast cancer. I have a granddaughter that's going to be born in May, and that's on the back of my mind now that this baby eventually will have to be tested for the BRCA gene. Who knows? Maybe it skips a generation. But anyway, that is my story, and I thank Senator Sievers Gansert for asking me to join in.
Thank you.
Will the next caller with the last three digits of 813 please slowly state and spell your name for the record? You'll have 2 minutes and may begin now.
Hi, Senator Ratty and members of Senate Health and Human Services. My name is Kendall Servino, Kendall Ser, V as in Victor, INO. I'm a medical student at UNR and more recently a breast cancer survivor. Being diagnosed with breast cancer at 20 years old was the biggest shock of my life and the hardest challenge I've ever had to face. Over the course of a year, I received chemotherapy, radiation therapy, and underwent 2 surgeries while finishing up my last semester of college and starting medical school. Losing my hair, losing my confidence, and gradually becoming unable to recognize myself in the mirror were the hardest parts of treatment for me, and an experience I hope none of you will ever have to relate to one day. I come here today to share the importance of BRCA genetic testing and of having this bill passed. After I was diagnosed, the first thing my doctor did was refer me for genetic testing. This was critical in determining whether my current or future family would be at risk. Identifying risk status is crucial in catching breast cancer early or before it even occurs. The number of lives here in Nevada that will be positively changed by this bill is tremendous. Providing genetic testing resources is the first step in mitigating breast cancer, a disease that has already impacted so many lives in our state, as demonstrated by all the testimonies before me. Thank you for having me today, and thank you, Senator Sievers Gansert, for introducing this bill.
Thank you.
Callers, if you've just now joined us, please press star 9 if you wish to give testimony in support of Senate Bill 251. Will the next caller with the last 3 digits of 237 please slowly state and spell your name for the record. If you're having trouble unmuting yourself, please try pressing star 6. You may begin now and you'll have 2 minutes.
Good afternoon, Chair Ratty and members of the committee. My name is Marlene Lockhart, speaking on behalf of the Nevada Women's Lobby. We want to thank Senator Severs Gansert for bringing forward such an important piece of legislation. My testimony included a number of the statistics and information that has already been brought forward by the other testifiers. So suffice it to say that these numbers are obviously significant. Ensuring that women are screened and those that are at-risk women have the ability to get genetic testing is critical to preventative care. This bill can and will quite literally save lives. We urge your support and thank you for your time today.
Thank you.
Chair, at this time, there are no more callers wishing to testify in support of the bill.
Thank you. Let's go ahead and open up the lines to testify in opposition.
Thank you, Chair. Callers, if you'd like to testify in opposition to Senate Bill 251, please press star 9 now to enter your place into the queue. Once again, to testify in opposition, please press star 9 now. Chair, at this time, no callers have indicated that they wish to testify in opposition to the bill.
Great, thank you. Is there anybody on the line who would like to testify in neutral to SB 651?
Certainly, Chair. Callers, if you'd like to testify in a neutral position, please press star 9 now to enter your place to the queue. Will the caller with the last 3 digits of 786 please slowly state and spell your name for the record? If you're having trouble unmuting yourself, please try pressing star 6. You'll have 2 minutes and may begin now. Once again, caller with the last 3 digits of 786, please slowly state and spell your name for the record. You'll have 2 minutes and may begin now.
For the record, my name is Erin Lynch, E-R-I-N, Lynch, L-Y-N-C-H. I'm the Chief of the Medical Programs Unit at the Division of Healthcare Financing and Policy. And the division is testifying as neutral on Senate Bill 251. Nevada Medicaid already covers genetic screening, testing, and counseling for BRCA1 and 2 gene mutations for women who meet the criteria in the bill. This includes policy coverage in Medicaid Services Manual Chapter 600 Physician Services and Medicaid Services Manual Chapter 800 Laboratory Services. And we also cover this for men as well. And we'd like to state that therefore, the Division of Healthcare Financing and Policy has a $0 fiscal note on this.
Thank you.
Will the next caller with the last three digits of 572 please slowly state and spell your name for the record? You'll have 2 minutes and may begin now.
Hi, I'm Robin Palmer, ROBBINPALMER. I'm a certified genetic counselor. My focus is on hereditary cancer. I provide hereditary cancer risk assessment to individuals and coordinate genetic testing for hereditary cancers. I'm also an alumnus of the City of Hope, Duarte, California, internationally recognized 10-week intensive course in cancer genetics. I'm the only practicing genetics professional in Northern Nevada, I believe. I've provided written documentation of my comments, more extensive than what I have time here. I think SB 251 is well-intentioned, but as a genetics professional, I have several concerns about SB 251, and those concerns mirror my concerns with the current legislation. Number one, who can provide genetic counseling is poorly specified by SB 252. Genetic counselors are not licensed in the state of Nevada, as they are in most other states. Genetic counseling is undefined in the state of Nevada, mirroring current legislation. SB 251 authorized, quote, certain providers to receive credit for continuing education relating to genetic counseling and testing, end of quotes. I know of no state of Nevada requirements for the amount of continuing education required, criteria for defining an acceptable course of instruction, how proficiency with genetic counseling testing is assessed, or how this provision is to be enforced. Two, the National Comprehensive Cancer Network, NCCN, has specified established criteria based on an individual's personal and family history of cancer, stating who is appropriate for genetic testing. SB 251 requires providers to, quote, screen women for BRCA gene mutation, end of quotes, and current legislation references screening based on family history. Some providers and patients think screen for HBOC, hereditary breast and ovarian cancer, means perform BRCA genetic testing. Many non-genetics providers do not take an adequate family history or regularly update a previously obtained family history. Many non-genetics providers are not aware of the NCCN criteria, which are updated at least annually. Many providers do not know the family history of other cancers, such as pancreatic and prostate, portend BRCA mutation. Many providers do not know that in an affected woman, certain pathological characteristics of her breast cancer suggest hereditary breast and ovarian cancer. Hereditary cancer risk assessment is difficult and takes extensive and continual training to stay abreast, no pun intended, of the complex and evolving specialty of hereditary cancer. Three, recommended by the National Comprehensive Cancer Network and accepted practice by genetics providers, is to offer broader genetic testing for hereditary breast cancer than just BRCA genetic testing. When considering personal or family history of breast cancer, a knowledgeable provider will consider genetic testing of several other genes that, when mutated, increase the risk for hereditary breast, ovarian, and other related cancers. Genetic testing will be negative if the gene that is mutated is not included in the testing. 4, genetic test results are prone to misinterpretation by unknowledgeable providers. Genetic testing often does not provide a simple yes or no answer. A genetic test result may be of uncertain significance or require additional testing, such as a skin biopsy, to clarify its significance. Thank you, Chair Ratty and Senators, and I refer you to my written documentation, which is more extensive and has additional comments, but in the interest of time, I will stop there. Thank you.
Great, thank you, and thank you so much for making the effort to submit the written testimony so that we have the detail. We appreciate it. All right. Anybody else in neutral?
Chair, at this time, there are no more callers wishing to give a testimony in a neutral position.
I'll take it back to the sponsor to see if, well, first of all, let me take it back to the committee to see if they have any clarifying questions. Senator Harris.
Thank you, Chair Ratty. Senator Sievers-Gansert, I was just reviewing the bill again, and I wanted to note that a violation of Section 1 would still be a misdemeanor. And so if it's your intention to take away all penalties, you may want to get another amendment on there to exempt it from that as well.
For the record, Heidi Sievers-Gansert, thank you, Senator Harris. I appreciate that. Okay, got it.
Any other clarifying questions from the rest of the committee? Senator Gansert, I did want to just ask one question. So we had the testimony from Medicaid there that we're already doing this. There's no fiscal note because these are services that are already available, at least to everybody on the Medicaid population. And I think you testified earlier that we're already doing this with the rest of the insurance companies. And I believe you referenced federal law. I think it's part of the essential benefits that are included in the Affordable Care Act. By reference to preventative services. Is that your understanding?
Yes. For the record, Senator Heidi Sievers-Gansert, yes, for the record, it is part of the U.S. Preventative Services Task Force recommendations, which is what is relied upon for preventative services.
So I guess my question is why have the insurance components in the bill if these are things that folks are already doing?
In talking to LCB Legal, they said if we were able to put this in the bill, then we would preserve the coverage, even if it was changed at a federal level. So we want to make sure that Nevadans have access to this counseling and to the testing in Nevada. So that's why we're looking to put it in statute.
No, any changes in federal policy and Nevada is still good?
Correct. Thank you.
Great. All right. Any other additional questions? Any final remarks?
Thank you, Chair, again, for the record, Senator Heidi Sievers-Gansert. A couple of comments that have been brought up. One is about there's other genetic mutations out there, and we should be testing for those. Right now, federal code covers BRCA1 and BRCA2, and there are other things, and I think genetic medicine will be refined over the years. But I don't want to not have testing for these mutations, which we know can be very lethal because we're not doing other things, right? So if we can get testing for BRCA1 and BRCA2, when you looked at the pie charts that were provided by Dr. Slotnick, you can see the magnitude of how many people potentially could test positive and then what the outcomes could be. So I want to make sure that we do that. And then we had some testimony about counseling, and that's part of the reason I put the CME continuing medical education piece in there, because it does sound like we don't have a lot of genetic counselors, but what we do have are physicians and different types of practitioners who can learn more about genetics. And we do not have licensure. We're not at that level, and it sounds like other states may be. But again, once a individual is tested and if they're positive, they're going to have a relationship with their practitioner to make decisions. And the decisions may be that they go on birth control. The decisions may be that they have a mastectomy, but those decisions can be made between a patient and a woman. And I think that making sure that we have folks screened is extremely, extremely important. And there also was some discussion about what that screening looks like. And I can tell you there's some tools that are out there that have been out there. I was trying to find my document from the American Cancer Society, but it basically pinpoints some tools that are out there. But it's really looking at a personal history. So again, if you're under a certain age and you've had a cancer, certain types of cancer, or your family history, and as I would imagine all of you know, when you go to the doctor, they do your family history. So this is sort of one more step, a little step deeper in family history to identify those who should get referred and potentially tested. And I think that we can end up saving a lot of lives if we get the awareness up and the assessments and testing and done on those where appropriate. I appreciate your staying this evening for this bill and your consideration of this legislation.
Thank you. All right, we're going to go ahead and close the hearing on SB 251. By way of announcements, our next meeting will be held on March 23rd, and we do have a number of bills to be heard on that day, so I'll just encourage folks to go check out the agenda on Nellis on our legislative website to see what we might be talking about next Tuesday. And with that, I'm going to go ahead and open up public comment. This is the time for anybody who's out there watching that you may comment on any topic, not just those that were on the agenda. BPS.
Thank you, Chair. Callers, if you'd like to give public comment, please press *9 now to enter the queue. Once again, to give public comment, please press *9 now. Chair, at this time, no callers are indicating that they wish to give public comment.
Okay, well, then I guess that is a wrap. Thank you to our committee members for your good attention, to all of the sponsors who brought bills today. I would also like to express a special gratitude to the patients who joined us today on both bills, SB 175 and SB 251. It always makes these meetings significantly richer if we have the voice of our patients at the table. So thank you to everyone who made the time. And always, of course, Ms. Kamasi and Mr. Robbins, our LCB staff, and everybody at BPS and IT who's been keeping us going. So thank you, everyone. This meeting is adjourned. We'll see you at the next one.